Alright, so hey guys, this is EMT Helper. Sorry, I'm having that time to access my computer, that's my bad. But so I know a lot of you guys have been asking about NREMT questions and how to go about them. I did post a video on FizzDap, which seemed to do pretty good. You guys seem to get some help from it. And my apologies, I won't be posting questions or anything like that just because I don't want to get in trouble with that, considering that this is my job and all that. Outside of the actual YouTube videos. But yeah, a lot of the questions will be posed in a certain way, and that is what this video is going to kind of go over. I've had a couple of buddies who've gone through and done this whole thing, the NREMT recently. I talked to a couple of them, see what the best way of organizing this was. So first things first, organizing the questions. So a lot of you guys who've done FizzDap will notice the structure of the NREMT questions will be very similar, if not the same, to the actual questions themselves. So the NREMT's questions will be posed in a very awkward way, almost asking you questions in a way that you won't understand them. So like a prime example of what should you do is what should you do first, basically. So, and I could be wrong about this. It's been quite a while since I've taken the NREMT, but you got to look at the questions and decipher the text, because there will be certain keywords that'll give away. There's something I will be putting down into the link of the description that was a video by the actual guys who wrote the NREMT, I believe in 2017 and earlier. So people who are very knowledgeable about the subject. And also I will be posting a couple of links to the question types themselves and the actual test itself that I helped use to review the criteria that I missed, or help review the criteria, and the test will tell you what you missed and what you're not as proficient on. So that's something you just got to make sure you're paying attention to. So there's a lot of good things to get into your head. Like I've really tried to, throughout these videos, push cardiopulmonary. So just a quick review on EMS history. We are actually part of the Department of Transport. Some people don't know that, but that's whatever. So we were actually designed in, I believe, the early 20s, 30s, that era, to be a system that responds to car incidents and responds to cardiopulmonary resuscitation. That's why, if you notice, a lot of the curriculum we're beaten to our heads through EMT school is generally consisting of those two, because that's where we began. Now, obviously, in the recent years, we've expanded to severe medical emergencies, severe traumas, all sorts of crazy stuff these days. We've got things introduced into our world like TXA, hemostatic agents, which a lot of that starts going into more of the paramedic level. But, and things like glucagon, would be more for like the diabetes, all that kind of stuff. We've been introduced a lot of different drugs, specifically a lot of the cardiac drugs, and we are getting introduced a lot of the drugs to regulate a few more things, I believe. I don't remember them off the top of my head, but our scope predominantly consists of vasodilators, cardiac medications, and all that. There will be a couple of people that I would suggest for paramedic courses, since I'm not that knowledgeable upon that. I haven't finished paramedic school, nor do I have any years of experience in paramedicine of that degree, that level, so I wouldn't want to speak on to that. So with the NREMT, a good rule of thumb is you can normally go back to your questions and see where you're at, and you can go over that and redo them, see what's going on, get yourself some help on that. Not help per se, but you can take the time to rethink the actual thing. But yeah, I'll be posting that actual link there soon. Big things that a lot of people do during the NREMT that I've noticed and talked to a couple of my buddies. I had one buddy who passed it first try, and another buddy who passed it several tries, and all that. All the big takeaway that I got is stress management is a key, because what can happen with some of these questions is they have a grading difficulty. So they get harder as you go along if you're getting them consistently right. So let's say, like, for example, like when I was taking my test, I remember I was taking EMT level questions. I was like, all right. It started off with questions like, what ventricle is responsible for pumping blood throughout the body, which is the left ventricle, right? Left ventricle connects to your whatever, all that, you know? And then the next question after that was a little bit more advanced. It was like, I think it was like something relating to CHF and what ventricle is responsible for rails presenting in the lungs or just fluid buildup in general, in which I believe that is, I think that is your left again. I could be wrong. No, your right's pedal, left's lungs, right? But yeah, so there's a lot of those questions, and then I remember my last couple questions were like paramedic operations stuff, so like how to diagnose the situation, go from there, all that kind of stuff. And I remember towards the end, I was getting extremely overwhelmed. I felt like I failed it, and then I know, like, right when it hit that, like, I think it was right before the 70 question mark, right when it got there, I freaked out. I was like, oh God, I think I failed. Biggest thing you need to take away from it is it's not a big deal to not pass it on your first try. Not everyone does. I've talked to hundreds of EMTs. A lot of them have issues passing the first try. That's completely normal. That's not unheard of. And it's not something to get down about. It's something that is supposed to make you the most competent medical provider that you can be. Though some people argue the efficiency of the NREMT, that's why a lot of people, and it's something that's encouraged by most people, including myself, to get a couple of years of IFT experience before you, or not years, sorry, months, like 3 months of IFT experience to get that patient contact, your assessments down, all that stuff. Because you got to remember, 2 to 1 year of school, 2 months to 1 year of school is not something that's going to be very helpful and conducive of making you ready. And IFT will get you into those non-stressful situations. Not necessarily, I mean, some companies, like, you know, I don't know, there's hundreds out here. The ones I think of off the top of my head with California is like Simon's, Mission, those ambulance companies. Those ones will be your ones that will generally hook it up on that information. They'll generally be pretty built for you to develop your IFT knowledge, and IFT knowledge is conducive of 911 knowledge because your biggest thing is to develop those soft skills, you know, developing patient contact and rapport, you know, waking up at 3 in the morning just to have some sort of, you know, toe pain call. You've got to learn and you've got to put in your time, you know, develop that thick skin so when you're on that call, you're not screaming and yelling at people, you're sitting there used to it. So that's a very important thing to get used to, is EMS is very trial by fire field, and first try is not going to be your, you know, first try is not going to need to be perfect every single time. Now, don't get me wrong, in the field, most of your first tries should be, you know, not technically even your first try, especially once you get to the medic level, it should be more, you know what you're doing. And that is the biggest thing you can do with EMS is practice, practice, practice. EMT school, the one I went through, was only a month or so long. It was very, you know, cut. And you got to remember, if you're going through a school like that, you've got to prioritize. You can't be hanging out with your buddies and all that. You got to study. You got to pay attention. There is no magical pill, no magical anything, no magical way to figure it out. I found the best way for me was studying and making it fun to study. There's models that people teach. I think the best one is 30 minutes of hardcore studying, a 5-minute break, and make sure you know that that 5-minute break is rewarding you for studying. Along with that, also is recognizing your task management. Make sure you have concise planning and you have a very set out plan on what you're going to do that day. So after EMT school, you've got to go out and be like, okay, so today I'm going to study cardiology because on my last FISDAP test, I got a 60% on that. And I don't think I was doing too good. So then you go out, you study that, and you make sure you're paying attention to that. A lot of people I've noticed, especially my buddies when they went through and they tried to do their NREMT, was that they would either go in studying improper material, like dated books, so avoid those. There's like some of the books that people will suggest are generally books that are helpful for field usage, like once you get into the field, but they're not necessarily helpful for the NREMT, because the NREMT is trying to get that knowledge into your head and keep it there long enough so that you can go through the test, and then you can come out into the field and have that baseline level knowledge, right? So it's important that you read over the actual book material. And remember, just because your book that you're given in EMT school is designed to get you through the NREMT does not mean it's the only source. What I stick to and what I believe is the best thing to do is go through things like the AHA, the NREMT's websites. I don't know if the NREMT has a website that does give you direct information, but I do believe there are materials the NREMT uses to develop their doctrine, which is also very important that you figure out those resources. Throughout the next couple weeks, when I get some more time, I will probably be posting a few more of these kind of videos about, exactly what you should be looking for, exactly what information. And I know this was a late post. That's my apologies. I should have been more on top of that. But yeah, if you guys want more tips or anything like that, please tell me. I'll gladly set some time aside to give you guys some tips about whatever information interests you guys. I should be going over a couple of those previous ones. I'm going to move away from using it kind of like the book and just kind of making slides out of that, and move into more kind of videos like this where I can sit down and explain things to you. I might do live video eventually, but yeah, what I'm aiming for right now is more of something that you can kind of pick up, you can understand. I'm going to try and avoid using medical jargon and try and move layman terms into medical jargon, if that makes sense. So terms that you guys will understand now, like cardiopulmonary resuscitation and how the cardiopulmonary system is affected. Like most of you guys probably aren't off the top of your head going to understand that ventricular tachycardia and ventricular fibrillation are ventricular-based arrhythmias, right? So avoiding those terms and then explaining to you how those affect it, and everything from the vagus nerve all the way down the SA node, and how to diagnose these through EKG readings and all that kind of stuff. It's very important that you guys kind of take that time and realize that you guys don't know everything. I don't know everything. No one knows anything in EMS. That's kind of the awesome part about it, and the suck-ass part about it is you've got to take your time, learn through it, understand the material you're given, because a lot of the time the only thing you're going to have, especially on those crazy calls, is your critical thinking skills. And that is one thing that I think the NREMT starts helping develop, is those critical thinking skills. You've got to be able to read through that question, diagnose exactly what they're asking you, and then go upon that. Because there are certain ways and certain phrasing patterns that they will use that will give away exactly what they want. Some will say, in their little way, like, what are you going to do first? What should you do first, right? And that will be, okay, well, look at the questions. So let's say you come on scene, patient is presenting with they're pale, cool, clammy. Last known well was 15 minutes ago. Fell, hit the ground, complained of chest pain. All right? And they were on the ground holding their chest and they haven't woken up. Come there, you look at the patient. What is the first thing you should do? So we've got an unconscious patient, skin signs are not doing too hot, and clearly there was some sort of cardiac episode if they're clenching their chest complaining of pain, right? So what you do is you go down, and the very first thing might be BSI scene safety, because no matter what you're doing is you've got to make sure you've got all that body substance isolation. You got to make sure, especially in these times of COVID, you got your N95, KN95, whatever your agency gives you on. You got your face mask on if that's part of your protocol. You need to have your gloves on if that's always a part of your protocol. It should be. And then, though that might not be the first thing that comes to your head, that should be the first thing that comes to your mind, okay? Then next, after that, after your BSI scene safety, you start moving into your like, okay, what's going on here? The situational diagnosis. You've diagnosed the scene as safe. There's no spinning table saws that are gonna cut you in half, or crazy crackheads wielding katanas waiting for you to walk next to a closet or whatever. So that goes into that entire situational diagnosis. Once you've gotten that covered, now you've diagnosed, okay, we've got a patient on the floor. Well, let's move into our, since you don't know if he's breathing or anything, the first thing you do is assess for breathing. You assess for carotid pulse, which most of you should know. You just push it in right there, feel it. Oh, yep, you got a pulse, right? And don't get that confused with carotid massages and all that stuff. That's out of your scope. That's stuff you shouldn't be thinking about quite yet. That's stuff that moves into the more medic level and is only done with monitoring and stuff. Carotid pulse, make sure you check it. That is the direct link to the brain and the head, the heart, and that is where you're going to get the best pulse. Because think about it, you assess for your peripheral pulse, like right here, right? Well, you're not might not get a peripheral pulse, considering that there might not be blood flowing to it, or capillary refills, all that kind of stuff. Carotid pulse is the best one to get if you're in an emergency situation and your patient's unconscious. And it's preferable that they're unresponsive or unconscious in general, because if you've got a patient and you're shoving your finger into their neck, they're going to be tripping out a little bit. And a lot of what we're doing is trying to minimize, patients' fear, patients, what's going on in their head kind of stuff, okay? So after you've assessed for that pulse, you've got that understanding, like, oh crap, this patient, let's say in this example, you're feeling no efficient heart rhythm. You hook them up to an EKG and they're in VFib, ventricular fibrillation. This is normally diagnosed by your medics. Some states you'll be diagnosing this as an EMT. It matters heavily on where you're at, and if you're taking ACLS as an EMT, that kind of stuff. PALS, whatever. ACLS obviously being advanced cardiac life support. PALS is pediatric advanced life support. Each one teaches differently upon what you're supposed to learn, because ACLS might not necessarily teach you all the different EKG rhythms, which is why it's important to study no matter where you're at. You'll meet some of these people in this field that will be reading their books all the time, and you will know that's generally going to be one of your better partners, just because he loves this craft. This is what he wants to do. He's going to be reading and paying attention to the material and knowing what he's going through, right? So that's what you got to start learning to do yourself, because if you're getting into this for the wrong reasons, you're not going to be successful. So now going back to where we were talking about before I went off on the monologue about ventricular fibrillation. With VFib, it's a shockable rhythm, which is something you should have been taught in EMT school. Generally, if you're using an AED and you're a BLS only crew, you will have AED, which will diagnose shockable rhythms for you, right? So you've diagnosed a shockable rhythm, you've been in your cardiopulmonary resuscitation, you've moved down that entire process. Now you've hit them with a AED. Now they don't have a shockable rhythm. There's returning of color in the skin. You assess for a peripheral and carotid, or you assess for a carotid pulse. The pulse is returning to a normal 60 to 100 pulse. And then you start assessing peripheral pulses. You start moving down AEIU tips, just going through all that while focusing predominantly on getting this patient on the stretcher, getting him to the hospital. Preferably, if they're hooked up to the EKG, diagnosing exactly what kind of electrical rhythms going on in the heart, because for all you know, this guy could have a STEMI or a non-STEMI, and your medic needs to get him to the nearest STEMI PCI center as quickly as possible. So that's another thing, is, a part of operations is diagnosing what centers you need to take them to, diagnosing your centers in the area, that kind of stuff. So reviewing that entire situation that I brought up, just to kind of keep it short, it's first things first, BSI scene safety, always your first thing. Then you diagnose your scene, you examine your scene, see what's going on exactly. And then, because the biggest thing, I know some people like the acronym PENMAN. I think the most important part of PENMAN is environment. If you walk into a room and you see a healthy 26-year-old patient, you see large amounts of alcohol on the ground, and large amounts of caffeinated beverages, opened and emptied, and then you assess the patient, you notice that they've got a fragrance on their breath that smells like alcohol and energy drinks, you might not need to think, oh crap, this guy is in a bad rhythm, whatever. He might just be an AVNRT, and you might just need to go hit him with a, pulse check, see his pulse, like, oh shit, that's 200. AVNRT is a rhythm that is supraventricular that can actually be diagnosed and treated for by a carotid massage. Granted, you cannot diagnose this in the field as a EMT with just these simple details, so it's preferable that you get your EKG, diagnose what's going on, then you move for treatment. And then again, these are things an EMT shouldn't be doing because these aren't even taught in ACLS. These are taught more at the paramedic level when you start moving on to the 12-lead diagnostics and, getting past that basic VFib, VTAC, AFib, that kind of stuff. So along with that is once you've diagnosed the scene, now you move on to the diagnosing of the patient. Now that you've moved on to the patient, you assess for carotid pulse, you assess for breathing, and then you move on to what you're going to do, your CPR, your BVM, all that good stuff. And then you move from there into, your final steps. If you achieve ROSC on scene, post-ROSC care, if you don't achieve ROSC on scene, what is your protocols by company? What's your protocols by county? What's your protocols by state? Now with COVID, they're pushing towards less usage of BVMs. They're pushing towards, 20-minute only CPR. Once you hit that 20-minute mark, call a code. If they're not revived on scene, you can't take them to the hospital. These are all things that, you need to make sure you're reading up with, you're keeping up with, because each county's different, each place treats it differently, and you need to make sure that you're on top of it. So it's important to make sure you're keeping up on all these things. And just one last time to make sure you go through BSI scene safety, which is always going to be your first thing as an EMT. There's a reason why it's always the joke. It's the butt of the joke. BSI scene safety. No matter what, BSI scene safety. Because remember, you're no use to anyone if you're a dead responder. Dead responder can't do CPR. Dead responder can't do anything. So you need to make sure your priority is you and your partner at all times. And this can be seen with the Tucson incident. This can be seen with the Station 81 incident. All these incidents right now, not as much the Tucson incident, that was just a random act of violence, but the Station 81 was that scene safety. There was people being crazy, right? Next up, you need to diagnose your scene, see what's going on in the scene, understand what's going on. And mind you, this should be tops. This should be immediately processing. This should be 30 seconds to a minute, no more, no less. It should be actually while you're doing your patient assessment, understanding and seeing what's going on, being hyper observant of your environment. Next up, diagnosing your patient. So diagnosing your patient obviously is a little bit different. And a lot of protocols will do the ABCs, all that kind of stuff. Unconscious patient, carotid pulse, breathing. Keep it simple, okay? Now, that also is ABCs at its finest, because if you're checking if they're ventilating, then they're probably breathing and their airway's patent, because it's very hard to push air through a closed airway, if at all. So best way to determine is ventilation. Now, ventilation doesn't necessarily guarantee that they're being adequate or they're actually getting what they need through their body, but it just shows that they're doing what they're doing, And then obviously your circulation. If it's not an immediately life-threatening issue, i.e. they're in a state that requires CPR, which is apneic, pulseless, any of that kind of stuff, or in peds and neonates. Neonates specifically, I think the pulse rate for them is 30 before you have to begin cardiopulmonary resuscitation. I forget pediatrics off the top of my head, but I would imagine if they're nearing the 1 to 0 range, forget the exact ages of neonate. I believe it is 1 year, but that also matters. Besides that, I'll go into that one if I review pediatric neonate. But yeah, after that, post resuscitation care, all that kind of stuff. So yeah, that's kind of how you should be looking at it, is looking at exactly the very first thing you would do. And then, maybe the question might ask you, what what would you do, I believe, is the one where they're asking very first thing. So what would I do? I would assess BSI safety, right? If that's the question being asked. And then next up, um, I believe what should you do is the one where they ask, and that is, what should I do? What should I do is probably begin assessing the patient, and that wouldn't be wrong. And then what should you do first? That is back again to the assessing the patient's BSI scene safety. So my apologies for the 25-minute long video. I know this is probably a pain in the dick to watch. I'll try and cut them down because I know it's probably not fun to watch them. I'll try and keep them around 5 minutes and try and make them very concise, informational videos. The next following videos are going to probably be going over a few of the whatever you guys need. I've noticed that you guys wanted help on this, and I will put all the links I told you in the description. Have a great day. Feel free to ask me questions. And yeah.